Hello everyone, this is part 2, and in part 2 here we are focusing on skin cancer. This slide we previously saw in the last lecture, as well as this one and this one. What we're doing in this particular screencast is illustrating some of the different examples of skin cancer or potentially skin cancer. This is not skin cancer, this is a nevi, pigmented or non-pigmented lesion that forms from aggregations of melanocytes beginning early in life. So this is a mole. Most moles are brown, black, or flesh-colored, various sizes and thickness, seldom undergo transition to malignant melanoma. Seborrheic keratosis, this is a benign proliferation of basal cells occurring most frequently after middle age and presenting as multiple lesions on the chest, back, and face. These lesions often appear following hormonal therapy or inflammatory dermatosis. Areas are waxy, smooth, or raised lesions that vary in color from yellow to flesh tones to dark brown or black. Actinic keratosis. This is a skin disease resulting from UV ray exposure. There is abnormal cell growth causing well-defined crusty or sandpaper-like patch or bump that appears on chronically sun-exposed areas of the body. Bowen's disease is another pre-malignant state, can occur anywhere on the skin or mucous membranes, presents as persistent, brown to reddish-brown scaly plaque with well-defined margins. Now, this is the most common form of skin cancer. This is non-melanoma. It is basal cell carcinoma. It's a slow-growing surface epithelial skin tumor. 100,000 new cases each year. Caucasians are affected. It rarely affects African Americans or Asian Americans. Squamous cell carcinoma, usually not life-threatening. It's the second most common type of skin cancer. Can take the form of persistent scaly red patches that sometimes crusts or bleeds, or it's an open sore that does not heal. Here's an example of squamous cell carcinoma. Malignant melanoma. This is a neoplasm of the skin originating from the melanocytes. 4 clinical types that we're going to see. A is superficial spreading melanoma. Has an irregular margin with multiple colors of black, blue, pale red, and white. B is a nodular lesion of melanoma. This lesion developed on top of a nevi. It's small, quickly enlarging, uniformly and darkly pigmented. C is a lentigo maligna. Looks like a large freckle with irregular border and varied pigmentation. And then D is acral lentiginous melanoma. It's a flat lesion with dark brown portions with raised bumpy areas. Now, if you look at those and you say to yourself, I can't tell the difference between them, the good news is you're training to become a physical therapist. You don't have to. But what you can do is apply the ABCDE criteria. And if you were to see something that didn't fit within the ABCDE, make a referral to that patient. For example, in A, we have an irregular border. Same thing in C. A and C have multiple colors. B has an elevation to it. And D looks fairly large in size with irregular borders. So again, the A, B, C, D, E, we saw those in the prior screencast. We also saw previously the guidelines for the prevention of skin cancer. If you need to read through these again, go ahead and pause the recording. Now, some additional things to take a look at. Kaposi sarcoma. This is a malignancy of vascular tissue that presents as a skin disorder. Originally, it was most frequently seen in older men of Mediterranean or Eastern European origin, especially men of Jewish or Italian ancestry. Now, the incidence of this is increased related to AIDS-associated immunodeficiency. This may also occur in individuals that are taking immunosuppressive drugs. It's caused by the herpes virus infection HHV8 or Kaposi sarcoma associated herpes virus. The exact mechanism of transmission is not known. Diagnosis is made by a skin biopsy. CT scan may be used to detect for possible metastasis. Can be life-threatening. Treatment is antiretroviral therapies. Chemotherapy can get resolution of Kaposi sarcoma. Let's look at some skin disorders associated with immune dysfunction. Psoriasis, this is a chronic inherited recurrent inflammatory but non-infectious dermatosis characterized by well-defined erythematosus plaques covered with a silvery scale. Cause is unknown, appears to be hereditary. Psoriasis may be triggered by mechanical, UV, or chemical injury, various infections, prescription drug use, psychological stress, smoking, pregnancy, or endocrine changes. Cold weather and severe anxiety tend to aggravate it. Medical management includes a variety of treatments. Physicians may take a trial and error approach using topical preparations, possibly phototherapy, so exposure to UV light. Antimetabolites, these are a group of anti-cancer agents that exert their cytotoxic effects by interfering with DNA synthesis. Oral retinoid therapy, these can help to decrease skin inflammation, and immunosuppressants. Lupus, this is a chronic inflammatory disorder of the connective tissues. The exact cause is unknown, possibly autoimmune in nature. Treatment, topical and systemic medications. Avoid prolonged sun exposure or fluorescent lighting. Some thermal injuries, cold injuries, result from overexposure to cold air or water. Two major forms, localized injuries like frostbite or systemic injuries like hypothermia. For a localized injury, rewarm without rubbing or massaging. Use supportive measures, analgesics for pain. Blister management, treat with topical aloe vera cream and dressings for the wound. Hypothermia, get out of the cold, remove wet clothing, provide warm beverages, and cover with blankets. These can become a medical emergency if severe. Burns, injuries that result from direct contact with or exposure to any thermal, chemical, electrical, or radiation source. These occur when energy from the heat source is transferred to the tissues of the body. The depth of injury is a function of the temperature or source of energy and the duration of the exposure. Some PTs may work in burns or burn care, usually a specialty area that people get into. There is wound care for minor burns, removal of damaging agents, so whatever is causing the burn, to remove it first, then debridement of loose, non-viable tissue at some point in time as things have stabilized. Application of antimicrobials or ointments and sterile dressings. Obviously, this is just a very cursory overview. Nursing oftentimes does handle a lot of the wound care, but again, some PTs may specialize and get additional training beyond their education to work with this patient population. And oftentimes, this is a patient population where we're talking about individuals that have had severe, extensive burns throughout their body. And there may be post-operative care, post-operative protocols to follow if somebody has had skin transplants.